Our methodology, we had the sites Machakos, Nyeri, Isiolo, and Kisumu. Specifically, we had a reason why they were chosen. Machakos has high prevalence of road traffic injuries. Nyeri is non-communicable diseases, and Isiolo is pastoral community, nomadic sort of, and then Kisumu is communicable diseases. So that is basically why they were chosen to be participated in the county. We use exploratory qualitative study, so we don't have numbers. The target population were women of productive age, caretakers, and the data collection tools, focus group discussions, and in-depth interviews. And sampling procedure was purposive, and of course we sought ethical considerations, and interviews were taken through consenting process. So I'm going to talk about how it was planned briefly, and the mobilization processes and registration, and then the implementing patterns thereof. So on onset, in all the counties, they had meetings. Of course, when they just announced, there wasn't really an elaborate plan, but managers had to quickly sit down and plan how this was going to be done. They were trained to go and take the information through mobile phones, and despite the good intentions in planning, some of the communities did not feel they were involved, as some of the quotes were saying here. And in some areas, a critical mass of people were not involved. We have not been involved as a committee. This is coming from the MCS, that they were not involved fully in the planning. Trainings of the CHVs, yes, they were trained, but how to take the information. Most of them were also not really elaborated on what UHC was, but they were trained on technology of how to take the data using the technology. When you come to community sensitization, yes, the CHVs were also supposed to go to the committee and sensitize them, but it was sensitized also through the media, and also the political class went along with the vehicles announcing in their communities that there's a free health care. And that's why people started now suspecting and saying, this is Illuminati, we've never seen this free. What is free? How can we get free? We've never had it, we've never experienced it. Because of the political class involvement and saying there's free healthcare, they thought now, this is just, they want to steal our votes, they're scheming again. So that's why we had some mixed feedback. For example, we were asking the population what is UHC, what they knew about UHC. And you see some of the members are saying, I understand it is as a card, like for NHIF, because there's NHIF and some other platforms. And others, like the health workers were saying, like, we were just ambushed. We were told to take up this course. We were not prepared. We did not fully understand it. So they were saying, like, we were just ambushed. So most of our people they were living some distance, very far from hospitals, like especially in Isiolo, the nomadic places. And therefore, all this information did not reach them adequately. So possibly due to limited sensitization, then we had all this feedback, because at first most people were refusing, because they were like, why are we registering? Just the way our colleague was saying. Some had it from the government, but they were not even accepted as why it's free in the first place. So this inadequate information about UHC, just as my colleague has also alluded, you see the implementing partner is saying NHF card is a card that you can use outside your county. Okay, but the members who are seeing that it is like the UHC card and the NHIF card are the same. So I can go to Isiolo and use services there. I can still go to Nyeri and use the services there. But that is not the case. If you are registered in Isiolo, you use the card in Isiolo. Yeah. So all those clouds, it was not really explained to people to understand what it really was. When it came to registration, yes, the concept was accepted a little bit. They enrolled the youth to register, and then the CHVs also, because the CHVs were not enough. And then there was a sort of like confusion, because they did not understand health issues, the youth that were actually enrolled in it. So some of the challenges were, even up to date, there are some people that have not been registered. There was a delay in getting registration cards. People were we are supposed to register you in the phone, then you get the card, then the card will take you to the hospital. But you find that some people were registered, but they don't get those cards to make them access to the hospital. Nevertheless, when they reached at the hospital, they could actually be registered there and then they access the services. You see, there are some people who have not been registered. I would request that we be added more time so that everybody can be reached. This is a focus group from the community health volunteers. The issues of missing ID cards and birth certificates, of course, which were a requirement, again, as my colleague had alluded, and somebody has said that this and FGD, anyone above 23 years cannot be registered. He needs to have an ID. And some areas, people actually don't have that ID at all. Mobile phones ownership was also a challenge because this was an technology issue. So you had to have a mobile phone. Now, if you don't have a mobile phone and you don't know how to use, and there's no internet, it was actually a problem. Internet connectivity, of course, it was another challenge in registration. The role of implementing partners, they played a key role. Actually, they played a key role. First of all, they had to sit with the managers and talk to the health managers and to focus areas that really needed UHC intervention. So our role as a partner in the county is to bring focus on areas that are critical to UHC. That they had meetings with the health managers and that they had to discuss about it. Another thing they did, they identified issues of documentation. It was not being done. Nobody was really taking those processes and actually taking that data. And they were actually in handy to really document the experiences they are having so that they can document for the next level of scale up. They can now show where the challenges are and where the challenges are not. For example, this organization, the implementing partner, my organization is the partner that coordinates recruitment. They were recruiting the community health workers, training them, giving them all the necessary logistics, giving them the necessary materials so that they could actually now recruit the communities and the families together. So they really played a major role in this phase of place. So in conclusion, inadequate sensitization resulting to misinformation and misconceptions of UHC could have been contributing factors to the registration process challenges, and there were pockets of people where they were not registered to internet connectivity, and not all stakeholders were involved in rollout of UHC. Some of the recommendations would be just, if you're going to do this, if any country is going to do this, they need to take stock. Adequate sensitization is key so that people are not having this, these other ideas, thinking, what is this? This is political. Now we are going to steal votes. Now we need also to think about how we can roll out and how we can scale up this if we need to use technology. Registration, of course, should be a continuous process. People are being born, people are dying, so it should be a continuous process. It should not be a one-off thing, so that some people can miss out and bring those challenges. And then, of course, the role of implementing partners cannot be overemphasized, just as we had in the morning. Acknowledgement, Ministry of Health and county governments, Kenya Medical Research Institute partners and participants, and thank you.